I wanted to take a couple of minutes and respond a little bit about the post or a social media post that I put out there yesterday that was brought to my attention. Well, first off, about my post. My post, for those of you that looked at it, was just a very concise conceptualization or model, if you will, of some basic recommendations on how to increase volition or choice for adolescents and or young adults, and at the same time to decrease or to provide the least coercive intervention in situations where adolescents or young adults are entering treatment with any form or any burden of coercion. So, there's coercion. By definition, there's a lot of definitions out there in the literature, but just in a very broad sense, which is what I intended it to be, just really encompasses any form of treatment that is being imposed on an adolescent or young adult against their volition or against their choice. So again, that's a pretty broad definition, but a lot of the literature and research that has occurred really applies to all of that. But just to address, briefly, some of the things that are brought to my attention. First off, where did I get the information that I included in the model? So, as many of you are aware, especially in the private mental health and behavioral health industry, there's essentially no research out there, especially with adolescent populations, and again, especially in the private sector. So what I did, and I spent a couple of years. I've been doing this since 2011, or actually even 2009. Been going through various research databases and just accumulating a large volume of research from a lot of different sectors of mental health. And so even though there's no literature or very little literature in the private sector, I've been able to glean and really extrapolate from literature and other aspects of mental health, whether it's psychiatric nursing or court-ordered populations, or just a variety of different contexts and settings. And so that's important because this is a general, and that's why I listed just a very general outline versus getting too specific, because we can't get too specific with this, with the recommendations and with our approaches, at least from a research perspective, until more research is conducted within the private sector and with adolescent populations and young adult populations that we're actually working with and treating. So that's why my model is just meant to, it is very general, very broad. You may read through it and think, wow, this is just, really an outline. It doesn't really give specific recommendations, and you're right. It's intended to be an outline that can then be applied specifically to certain situations. So just to I want to kind of do a series of response videos just for time's sake, and just to save you the time of having to watch me for an hour's worth of time going through the entire model. And I'm just going to break it up and just hopefully spend a couple minutes with each video that I'll be submitting out over the next few days. And at this time, I just wanted to address the least coercive intervention side and just a portion of that, of really that recommendation there. So in the literature, I'm not going to get into, and not in this video, of all the negative effects that have been tied or associated to coercion, but I will mention just very briefly that there are a lot of negative implications that have been empirically linked to coercive treatment, and more importantly, the experience or the perception of coercive treatment. And that's the experience or perception is really more important, because that has to do with not just the actual apparatus or source of coercion used, but that's how the individual actually that experiences the coercion. So that's really kind of the focus, and what, where a lot of the effects have been showing in the research. It's not so much specifically. I mean, there are certain things obviously that you don't want to do when you coerce, someone, or when you're admitting an involuntary or reluctant individual into treatment. And there's some obvious ethical things that you want to avoid or don't want to consider. But in terms of the research and where the effects are being found, they're being tied to more of the individual's actual experiences or subjective experiences and perception of those events, if that makes sense. And so I may get more specifically into those effects and things later on if people express an interest. But for now, I just want to address this concept of the least coercive intervention. So there's an article that I'm going to post. I'm going to post a link to, or not a link to it, but a reference to it. I do have the article. If anyone wants to contact me personally, I'd be happy to share it with you personally. But not everyone has access to research databases and so forth. But I will provide a reference to that in this video. But there's an article by Brien and Golding, published in the Journal of Psychiatric and Mental Health Nursing in 2003. And I got a lot of information from this off of there. I read a lot of other articles from other disciplines and more recent articles. I just felt that they conceptualized it really well. And so I used, I put their recommendation here. And so they said, and they're not the only ones saying this, but in this article, O'Brien and Golding argue for a process of justification for both the use and extent of coercion in any type of coercive situation. So any time that an adolescent or young adult is being recommended or admitted into a program that they are not choosing to go to, and it's not always that they're being transported, they're not always being physically forced, but that they're going to really just against their will, that they, they ideally would choose not to go there. There needs to be a process of justification for both the use of coercion and then also the extent of the coercion used. And this is really intended, again, not to just be a general guideline or general outline, because each situation, what is viewed as coercive and what source of coercion is needed, or the extent of it, what's appropriate, and the effects of coercion is going to vary based on diagnosis, based on personality, based on family issues, and so many aspects that really a consultant or a mental health professional working with the family really need to be there helping make those determinations and recommendations for the family and for the child. So in this process, O'Brien and Golding suggested that we need to determine the competency of the individual. So in most cases, especially with adolescents, because traditionally we've just automatically assumed that adolescents are not competent. And so therefore, the paternalistic justification of coercion, or the parent, being able to make that decision and what they think is best for the child, it has kind of just been made automatically without any consideration. Well, recent research, depending on your definition of recent, we now know that adolescents, that the level of competency varies across adolescents, and it also varies with the adolescent. Most adolescents, or just generally, the research shows that adolescents are cognitively are very competent, but in practice lack competency. So, in other words, they're capable of the same reasoning abilities as adults, but when it comes into actual practice, they're not making as effective of decisions. So, just as a quick example. An adolescent may be able to determine as easily, or as well as a 35-year-old, for example, that they need help, that they need treatment. But when it comes down to making the decision for treatment, an adolescent's going to be less likely to actually ask or seek help or make an effective decision based on that reasoning ability that they have. So that's where there definitely is a need for other authority figures to, in certain circumstances, be able to make decisions even against the adolescent's choosing, because like I just explained with what the research has shown, the adolescent may actually know that they need help and want help, but they're not going to actually choose it on their own, which kind of leads into another discussion that I'm not going to get into right now. But ultimately, we need to be determining, the consultant, the mental health provider, psychologist, therapist, admissions counselor, you need to be determining the level of competency of the adolescent. Some adolescents are competent enough to make those decisions. And I would say most importantly, or where this comes into play a lot, is after the adolescent is in treatment, wilderness programs are very commonly used approach, especially in the private sector. So an example of how this would play out there would be, maybe initially the adolescent, at home in the environment isn't really competent enough to make the decision of whether or not they go. And so the parents, there's an arguable justification for the parents to override their autonomy in making that decision. But, within 6 weeks or however long they're at the wilderness, their ability, their competency is likely to increase. And so once they become more competent and become more capable, it's very important to involve them much more in the process at the time. A lot of times, as traditionally in treatment, consultants and the program staff and the parents are making a lot of the decisions for excluding the adolescent out of the process. With adults, it's usually a little bit more different because legally they have to be involved. But with adolescents, a lot of times they're being left out of this process. And I found that this has transpired even after the adolescent is in wilderness. And this is probably, we don't necessarily need to, 6 weeks in the wilderness isn't going to, necessarily bring the adolescent to the point that they're capable of making every decision or even making the final decision. But depending on their level of competency, and again, this has to be done at an individual basis with the consultant, collaborating with, the actual therapist working and staff members working with the adolescent to see, how much can we involve them at this point in the process, with the decisions, not just for the wilderness program, but for treatment post-wilderness. And involving them in that process is going to have a significant impact in how they perceive and experience coercion and how they really adapt to the next stage of treatment, or transition back home. I mean, there's a number of different possibilities there. So I spent a little bit more time on that portion, excuse me, than I really wanted to. But there's also, they also talk about the need to assess in this process of justification. Also, that the use of coercion, or that the effects of coercion, that the positive effects of using coercion are going to outweigh the negative effects of not using it. So they're saying that we need to determine the competency. Then we need to look at the effects of using coercion and the specific form of coercion that's being used, and make sure that the positive is outweighing the negative, because there's going to be negative associations with coercion in most circumstances. But are the benefits justifying, the negative aspects of it, or the potential implications of it? And then really, the least coercive intervention needs to be provided, and that comes by an individual assessment. Whether then, just automatically, if you're a consultant and you have an adolescent that needs to go to treatment, and that needs to be coerced into treatment, rather than automatically recommending a transport, or rather than a transport automatically recommending one general approach that they use with all adolescents, there needs to be a more thorough assessment at this period in terms of what level of coercion does this adolescent actually need. And I'll get more into the details of that in another video, but I just wanted to go over the first part of the least coercive intervention section here. Please feel free to respond with any questions. I'm going to try to make the other videos a little more concise and shorter, especially in time. And please respond with any questions or specific things that you'd like me to address. Thank you.